Hey, Kel, it's great to meet you.
Great to see you too, Kevin. I appreciate this invitation.
Yeah, thanks. I've been, really looking forward to it, and really happy to have you on to the Building Builders podcast. Luke's been telling me all these great things about your chat at or your talk at Con Expo, and I'm really excited to learn more, and I think our listeners will be as well. So maybe just to kick things off, would kind of love to hear a little bit about yourself and what you do, and how you've started talking about the opioid crisis in construction.
Well, Kevin, this has been a long time passion topic. I've been involved in workplace mental health for many years. I'm a risk management, safety, health, and wellness practitioner dedicated to construction since 1996. Previously, I did work with public entities. So in the United States, that would have been counties, cities, school systems. And my work gave me a lot of opportunity to work with public safety. So police, fire, emergency medical services. I got good at helping tough professions talk about hard topics like workplace mental health. When I moved to construction, it came on the heels of a suicide prevention project in 1994, looking at suicides in jails. I thought that would be the end of my suicide prevention work, and little did I know that was just the beginning. But what I learned in my work with suicide prevention over the next 20 plus years is substance misuse and overdose are so closely tied between suicide that it just became an inevitable lane that merged. And opioids, with a crisis in North America, starting really in the United States in the late 1990s, it became inevitable that an industry like construction, with so many musculoskeletal injuries, would have a problem.
Wow, that's definitely a very interesting career, and it sounds like you're doing some really great work and helping out. So there's been a few waves of this crisis, I believe, with opioids, heroin, and maybe synthetic drugs now. Is that correct?
Yeah, the history is really sad with really pronounced waves. People are describing a fourth wave, and we talked about that at Con Expo. I had a colleague named Dr. John Gall. He's in St. Louis. He is another early adopter of the opioid issue in construction. We talked about those waves starting in the late 90s with the overprescribing of opioid when pain became a fifth vital sign. Even though it was subjective, it wasn't as easily measured as others. The situation was, in a developed country like the U.S., pain should not be a problem for individuals. And there's been a lot of litigation on the opioid crisis because of that overprescribing. What happened was then the legislators clamped down and the pendulum swung hard the other way with prescription drug monitoring programs, which stopped people who were using prescriptions from multiple providers. It was to shut down the pill mills that were manufacturing prescriptions and just filling them on the spot. And those were drugs that were being diverted for other use. So that was around 2010, the explosion in heroin. By about 2015, you'll see data that shows synthetics like fentanyl contributing to a large increase in the overdose rates. For the past several years, there's been a new trend. It's become more discernible. And about a week ago in the United States, the U.S. government declared action on a medication called xylazine, which is an animal tranquilizer that's been mixed with fentanyl. And on the street, it's known as Tranq. And that's being described now as the fourth wave. Some urban centers like Baltimore, Philadelphia, that xylazine has been in the system for the past 4 or 5 years, including like Los Angeles. But it's just becoming popularized because everyone was talking about fentanyl.
That's awful. That's terrible to hear. I really had no idea.
And with those waves, Kevin, like a doubling of overdose in 5 years.
Wow.
So it really eclipsed the rate of suicide in our country and in Canada. And suddenly the overdose rate became much, much higher.
So, based on industry research, we see that since 2021, it's 9 years in a row of increases. Is this what is causing that, or anything else behind it?
Yeah, in the United States, we have a group called the Bureau of Labor Statistics, BLS. It's part of the Department of Labor, which is where the Occupational Safety and Health Administration is based. So the BLS every year runs a report called the Census of Fatal Occupational Injuries. And risk management and safety professionals like myself wait every December 15th for that publication to come out so we can start discerning trends. And that was something that was hidden. It was off the radar screen. You really had to do a deep dive to find that trend, but it's something I've been talking about now for the past 5 years. Every year we're seeing this increase. So where in 2021, we had 8% of job site fatalities attributable to an accidental overdose on a job site. It used to be the overdoses were happening away from work, but over these past 9 years, it's been with increasing regularity that the overdose is occurring at work. And that's a sign of the prevalence of the opioid crisis and how prevalent and pervasive the problem is among the workforce.
That's absolutely shocking.
Shocking.
Why do you think we are having trouble getting control on this problem?
Well, the problem is deeply rooted. Obviously, one problem would start with why are people using substances? I think what happened with the opioid overprescribing, it contributed to a lot of new people becoming addicted. The myth was that OxyContin was not addictive, and they were spending $100 million per year on a marketing campaign to talk about the benefits of this long-acting, non-addictive medication, which turned out to be false. So that false narrative, doctors were taught, pharmacists were taught, the system became built around no pain. And that led to a lot of innocent people becoming addicted, doing what the doctor suggested they do to feel better. You want to have less pain, take this medication. It's good for you. It's not addictive. And by the mid to early 2005, 6, many of us in risk management and safety were aware of workers or family members who were struggling with the early signs of persistent opioid use, even addiction. We recognize whoa, there's a problem. The stigma around this issue, Kevin, is so huge. It was easier, honestly, to talk about suicide prevention before we could talk about mental illness. It took the pandemic before we could talk and write articles about substance misuse. So it made it hard for people to seek help. And once they were addicted, they were in the throngs of a broken system without adequate help and without a proper support network. It was kind of a perfect storm in many ways. It led to a lot of human destruction, not just loss of life, but loss of livelihood, broken families, destroyed people.
Do you think the pandemic has made this worse, or is it in some ways better that, it's opened up the discussion about mental health, or is it a net negative still?
Yeah, we always look for reasons to be hopeful.
Yeah.
You could say there's a silver lining, but the reality is the pandemic worsened or exacerbated this situation. You look at that rate, both in the US and Canada, overdoses before the pandemic and after almost doubled. In the United States, the first year of the pandemic, there was a 30% increase, followed by a 15% compounded increase. In Canada, before 2019, it was 10 overdoses a day. After the pandemic, it was 20 deaths per day, with a peak of 21 immediately post-pandemic. So in both countries that we're talking primarily about, you could see that being a real problem. The pandemic cut off people access to clinics, access to medication-assisted treatments. It cut off access to their recovery meetings. It introduced new drugs into the system. It disrupted the existing relationships people had. Maybe they had a source of medication that they were getting from a person with prescription. It moved more people to the street to find illicit drugs. And then that drug supply became contaminated. Fentanyl became increasingly more potent. It was being pressed into counterfeit pills to look like, medications that people were seemingly innocently purchasing, whether it looked like Percocet or a Xanax or another medication. It's so lethal that one dose can kill. And frequently, Kevin, I talk about fentanyl as fentakill just to get people's attention. You have to have these conversations with your children and your loved ones. One dose can kill.
Right. Yeah, and very, very difficult to get off of it after having that one dose,
yes.
Right?
But I do think what you said about the silver, I called it a silver lining. The pandemic has allowed us to have this conversation. It forced the hand. It took people who were reluctant or unwilling to have these hard conversations to recognize, if not now, it might be too late. And it has forced action. And so in that regard, I think we'll look back and say it was a turning point, if not a tipping point, to say enough is enough. We have to get this under control.
So we've been talking a lot about Canada and the United States. Is this mostly a North American problem, or is this a global issue?
Yeah. When I first started talking about this issue, it was mostly a U.S. issue. Then it became a North America issue for U.S. and Canada. Have not really seen a lot of data from Mexico. There are big differences in the way public health data is reported. Even in Canada, I believe most of the reports I see are generally from 7 provinces. But overall, this has been described in the research literature as a North America problem. When I've done webinars with co-presenters for the International Foundation of Employee Benefits Providers, we talk about it as a North American issue. I'm better with the data from the U.S., but the U.S. had about 4 to 4.5% of the world's population, but almost 80% of the prescribed opioids. So that points to just a huge concentration of the issue. And then globally, there's anecdotal reports with some lagging public health data pointing to growing issues with polysubstance overdose. So people overdosing with multiple substances that are now containing more opioids. So it's becoming more of a global issue, but most of the lens has been around the U.S. and Canada.
Gotcha. That's really interesting. What demographics are most at risk?
Yeah, wow. We call opioids an equal opportunity destroyer. It cuts across every demographic. If you do a deep dive on the data, you'll still see largely white Caucasian populations. But when you look deeply, you will see rising rates in persons of color, indigenous, and other minority groups. So there's a lot of concern about this being an emerging health equity issue, that it's having a disparate impact on persons of color, among others. So the demographics that normally we would look at would be between 20 and 59 is where a lot of the data points to. There's some data for some populations that it's 34 to 59. But we're hearing too many stories of children experimenting, not having had those conversations, thinking that they're buying a medication and that single dose can kill. We like to encourage parents of even preteens to teenagers to just have age-appropriate conversations, share information, let them know the dangers. It does cut across every demographic. It's really sad.
So you're recommending what, at age 10 to start having these conversations?
Usually it's in that 11, 12. They're starting to get some of this exposure in the U.S. to the DARE program, a drug abuse resistance education program. You're having those types of conversations. Doctors are having more conversations with patients in physicals about substance misuse and describing suicidality and talking about mental health awareness and condition. So it has become more of a normalized conversation, but just letting people know that the risk is real and to always help is always available, and that you should look for trusted adults who can help you make those better informed decisions.
So in terms of moving this movement forward, why is wording the problem in a human-centric way so important?
Yeah, I love that question. We frequently talk about that being person-centered language. We learned the importance of safe messaging with suicide prevention as well. We need to treat mental health like we treat physical health. And so when we think about this human-centered or person-centered language, it puts the person first. It doesn't put the illness or the disease first. I personally believe addiction is an illness, and the science has become more clear in that area. Many times when you talk about a deficit or a problem, people would point to that being a moral failing. But when we talk about person-centered language, you say things like a person is living with or recovering from addiction. They're seeking long-term recovery. It says they're more than that disease. They're a person. You're affirming them. You're speaking with empathy. It provides dignity, respect. It just allows a person to not feel judged and to not be shamed. And it highlights the unique capabilities and talents and strengths of each person as a living human creature. We deserve that basic dignity and respect, especially when you learn that addiction found many of these people, not through their actions or lifestyle choices, but doing what the doctor gave them, seemingly to get better. And so we try to take out the judgment, and we try to build the respect so a person has a better or easier pathway toward recovery. So I hope that's a really loaded question. It's more than hypothetical. It's true. People in recovery will acknowledge being treated with respect. They'll thank you after a presentation when you use this person-centered language. They'll say, that's the first time I've been to a presentation where people didn't call us addicts or junkies. And oftentimes they'll have tears in their eyes and they'll just thank you. I'll give you one example. I did a webinar. It was a year ago in 2 years ago, 2021. And 2 months later, I was doing a presentation on a job site with 500 people near Seattle. And there were 12 people who ended up attended that webinar, who came that day to say thank you for doing the webinar on addiction treatment and recovery. They came to show support, and they were the ones then who had me in tears, the way they were thanking me for just making a difference in their world. It was probably one of the most touching acts of kindness that I'd experienced as a professional. A group of people went out of their way to come and say, we want to support you. Thanks for supporting us. And the hosts at that meeting were blown away. Like, wow, we've never seen something like that. Nope. People are people. And if you treat people with respect, here's what can happen. It was one of the coolest things I've ever experienced.
Wow. That sounds so touching. And, frankly, great advice, like fairly simple to just, treat people well and, have this human-centric approach, but good to be talking about it and kind of the whole reason.
I'm really glad you asked that question. That's frequently overlooked. Kevin, if I just built upon that one more time, like a lot of times I do a program, either webinar or in person. We've called it Straight Talk, Addiction Treatment and Recovery. And I'll bring persons in long-term recovery to share their recovery journey. Those stories of lived experience build hope. And I did this last fall north of Boston in the US. And my 3 panelists were like, oh my gosh. So we were using interactive polling, asking different questions. And a couple of the questions were, did hearing these lived experience stories increase your knowledge about addiction treatment and recovery? And it was like 85% said yes. The second one, did hearing these stories increase your empathy and understanding of people in recovery? It was over 94% yes. My panelists separately said, we could see stigma melt. We came in, we saw people with arms crossed, people not comfortable having this conversation, can't believe we're going there, to wiping away tears, to recognizing this impacts almost every family. And many people told us after, we've never had this conversation. So that's why this person-centered approach is probably the most important thing we're going to talk about today.
Right. Yeah, I get it for sure.
Thank you.
I'm glad we're talking about it. Thank you. What do you think the biggest issue is? Is it overprescription from doctors? Is it people in construction not knowing how to balance their meds? Is it a mental health issue on a larger scale? Is it being afraid to open up and share feelings? What do you think is kind of causing this?
Specifically in construction, I believe the issue is a high rate of injuries. So remember, I'm a risk management and safety professional. I've been doing that for almost 35 years. Musculoskeletal injuries have a high percentage of prescribing for opioids for pain management. So this is a complex issue, but I would say the data supports this. In the U.S., there's a group called the CPWR. It's formerly known as the Center to Protect Workers' Rights. It's now known as the Center for Construction Research and Training, but they kept the same acronym, CPWR. The acronym no longer fits, but 34% of construction workers will experience at least one musculoskeletal injury. And the rate of opioid prescribing and use increases as you have multiple sprains and strain injuries. So that's one factor. A second factor is construction compared to all other industries. Again, using U.S. data, 55% of the time, workers in construction were getting an opioid prescription. That was twice any other industry. And another factor, it was demonstrated by a group called the National Council on Compensation Insurance. So they do a lot of rating for the workers' compensation. They found for construction, we had doses that were 20% stronger and durations of prescriptions for construction workers 2 times as long. I'm sorry, 20% longer, not 2 times as long, 20%. So 20% stronger dose, 20% longer duration, 55% of the time, construction workers were getting prescriptions. So here's the problem. Most patients prescribed opioids do not use all pain medication. You would think that would be a good thing. The bad thing is 90% of individuals don't properly dispose of the excess. We store those in a medicine cabinet. We keep them in the pill bottle. We save it for a rainy day, so I don't have to go back to the doctor in case it flares up. What if I re-aggravate this injury? Then I'll have some spare pills left over. That's called diversion. And what happens is that's where our teenage, young adults, guests in our homes are absconding, taking those extra pills. And that becomes another leading gateway of new opioid use. So
that hits home with me. I've got some young kids, and I'd be lying if I said I've never kept some pills, kind of just in case. Yeah, I mean, so great that we're hearing this as well. Really good reason to dispose properly of these extra pills.
Yeah, and there's simple products that are now available. They're drug deactivation or drug disposal products. Sometimes people will say, well, why can't we just throw them away? Well, if people know you have prescriptions, people will dig through the garbage. If they see a person who's had surgery or using crutches around the neighborhood, it's not been uncommon for their trash to be gone through. Or if you throw it or flush it down a drain, it ends up affecting the fish. Sometimes people said, well, I've buried them in my backyard. There have been examples as well of dogs digging up or other people learning where that stash was hidden. So these drug deactivation products are really effective at eliminating that problem so you can safely and environmentally safely dispose of that product. They're becoming readily available and fairly inexpensive. It's something I'm seeing employers really start to embrace. To say, hey, when we do a toolbox talk about opioid risk reduction, we're going to give you one of these drug deactivation products. Go home, search your house, look for excess, and then use the product that we've given you. I've seen some companies start to keep score. How many total pills did we discover and destroy? In construction, we like to make things a competition. There's always a little game element. Not
That's
saying that there's going to be the opioid Olympics for pill destruction, but it's one way to get people's attention that you can make a big difference with a simple campaign.
Yeah, I mean, that's great awareness and, kind of a fun way through some competition. Yeah, I mean, frankly, maybe it's just me, but I've never seen, these products before. I wouldn't have any idea how to get them. So I think, the talking about this is really great. It's a starting point. I'm now aware that they're out there, and hopefully others are, and we can go out and find them.
Yeah. One thing I'm happy to do is to provide you and Luke some additional resources. I know we're not trying to promote specific products. We're trying to keep it, quote, a generic conversation. But I think people will like to know about the category of products and where they can get those. And there's a nonprofit in the U.S. that I partner with very closely. They're called SAFE Project. It stands for Stop the Addiction Fatality Epidemic, safeproject.us. And they've been providing information on multiple products that are available. And if your podcast would like me to put together some additional resources that you could share, I'm happy to put something together. It would be not on a recommendation or an endorsement basis, just, hey, here's knowledge, information is power. You can share that with your listeners.
Love that. Yeah, thanks.
Okay.
We'll definitely take you up on it for sure.
Good. I'll make a note of that.
Perfect. I've got a few more questions I want to ask you. So how much emphasis do you think should be put on companies to provide benefits? And how much should be put on doctors in the medical system?
Yeah, it's interesting. The healthcare system, and especially big pharma, took a lot of black eyes on the issue of opioids. With the opioid litigation settlement dollars here in the United States, upwards of $60 billion over a 18 to 30-year payout. That's a lot of reparations for harm that was caused. So the pharmaceutical industry is trying to learn. The medical system is trying to learn. A lot of it comes down to individual consumers. One thing I noticed in construction, there's a power difference between the worker and the doctor. And so many times the construction worker is afraid the doctor's going to say, if I ask too many questions, well, where did you go to medical school? Just do what I asked you to do. Take the darn pill. So I had a lot of reluctance from workers. I had to stay in the non-medical lane as a risk management professional. So I'd have to say to employees, I don't want to know what medication you're taking. I want you to know that there might be side effects. So if anyone is taking opioids, I want you to be aware there are side effects. Did the pharmacist or the doctor talk to you about those? And almost always I get a blank stare. And then someone would say, well, what kind of side effects? Well, constipation. And if they get so severe, it's going to be something known as impaction. And people would start to chuckle in a really awkward conversation. But people then would say, oh my gosh, my grandson is having his wisdom teeth taken out. Are there alternatives to opioids? You talked about that last week. Actually, there are. Well, how come the doctors don't mention it? Well, they think you're going to need opioids. Again, I'm not giving medical advice. I'm giving you risk management and safety advice. Go and ask better questions. So, Kevin, that's the frustration. Workers, including those people in long-term recovery, would be prepared for surgery, and they'd ask, what's my pain management? Don't worry, we've got that covered. You're going to get opioids. You're going to need opioids. The pain's going to be so bad. And workers would say, but you don't understand. I'm in recovery. Yeah, but that was for alcohol. It's an addiction. I don't want to do anything that puts myself or my family at risk. Or people who had awareness of this risk would say, I don't want to have pills in my house. I don't want to expose my children. So there was a lack of listening to people who were raising questions. And that's why we've made this such a prominent topic. We are teaching people how to ask better questions, to be informed consumers, that alternative pain medications do exist. And the National Safety Council has been promoting what's called multimodal pain relief. There's research that will show that opioids are not that effective for surgical and even post-injury pain. It's better for chronic long-term pain, people with end of life, people with cancer, or other debilitating pain from certain diagnoses and conditions. Over-the-counter pain medications have been shown to have 3 times the pain management strength of opioids. And yet, opioids are still the first line of defense rather than like the last line of defense. So a lot of the education that we're doing in the employee benefit side is to teach people, ask about these alternatives.
Interesting.
Sorry, I got wonky there.
No, that was a great story. Are there any signs that progress is being made here?
Yeah, you have to, again, always look for signs of hope. I feel sometimes like I'm a perpetual rainbow seeker. I'm always looking, where's the good news? Where's the sun shining in the storm, right? So one piece of good news I'll give from Canada, there was a reduction in 2022. So the first 9 months of data for 2022 showed an 8% reduction in Canada in overdose deaths. January to September of 2022 compared to the prior year. That's a sign of hope. In the U.S., there has been some signs of a leveling off of that rapid escalation of overdoses. But more fundamentally, I think there's a couple of things that give me hope. One would be in the U.S., Narcan, medication known as naloxone, is now available or will be as an over-the-counter. On March 29th, 2023, the FDA, Food and Drug Administration in the U.S., gave approval. We're still going to have supply chain issues. We're going to have distribution challenges. We're going to have inequities in terms of when it's stocked and can people still afford it. But I take that as a sign of progress. And we're starting to see a movement called recovery-friendly workplace. gain a lot of traction. It started in the state of New Hampshire in the U.S., 2018. There's now 30 states in the United States that are embracing these recovery-friendly workplaces. Sometimes they're known as recovery-ready, or sometimes it's known as workplace-supported recovery, where companies are saying, wow, when we hire people in long-term recovery, they're really good employees. They stay longer. They take less time off. They're not dealing with as many issues because they've got their challenges under control. And I would say in Canada, I should have mentioned this in sequence. In Ontario, Narcan has been required to be on job sites later this year in 2023.
Really?
I think your provincial governments have been funding. I'm more familiar in Ontario with major funding initiatives that have occurred around mental health, substance misuse, and overdose prevention. Those are the signs of progress that give me hope.
Yeah, I mean, that's great news.
It's good news.
What can we do to help if we see people in our network showing signs of addiction?
Yeah, don't bury our heads in the sand. Have a gentle, private, supportive conversation and just ask, hey, how's your relationship with alcohol? Are you satisfied? Are you doing okay? It seems like you've increased your consumption. You're not the same person when you're drinking too much. Don't wait for it to get better. And then challenge your beliefs around addiction. I used alcohol as an example. There's so many states and countries where marijuana is being legalized, and yet there's a lot of evidence that points to that being a gateway to other drugs, especially for younger children. So just have the conversation about risks, have the conversation about help, have the conversation that addiction is a disease and you can take steps to prevent it, that recovery is available. And most of all, challenge the assumption that persons got to hit rock bottom before they're going to find recovery. When we wait for someone to hit rock bottom, they've depleted their recovery capital, the resources that are going to help them find recovery. They're going to damage their relationships, destroy their finances, possibly lose their job. Then they lose their benefits, right? It's this vicious cycle. We need to intervene quicker with support, with empathy, some compassion, being concerned, and offering a hand up to say, let me help you. I value you. You're an important person to me. I care about you. I care too much to not say something. I care enough to jeopardize the quality of our friendship today. But when you look back, you're going to say, I was the person who was there for you. And then check in if that person is not making progress. Let them know, hey, I still care about you. There's a lot of things, but it starts with that conversation.
Yeah, great advice.
Kevin, we talk about this being the elephant in the room in our industry, but also in our families. And when I'm having conversations with employers, especially if I'm leading workshops for their foremen, superintendents, project managers, and executives, I'll ask them polling questions anonymously. And frequently, alcohol and other substances will be toward the bottom of risk factors they're expressing concerns about. And I'll say things like, don't miss the elephant in the room. What happens when we enable and the elephant continues to linger? It gets bigger. And then the bigger the elephant, the bigger the mess. Right. And then you're a push broom guy cleaning up after circus elephants, right?
Right.
That's a mess. If we address it when they're smaller elephants, we can prevent a lot of the problems.
Right. Yeah. Great advice. Cal, what resources are available for those that don't have company benefits?
Yeah, I think what's really important is we have to lead people to thinking holistically. And when a person is in the throes of addiction, it's going to be exhausting to probably find those resources. I think in both of our countries, some places more than others, you'll see some governmental supported recovery resources. So that's one. Number two, your primary care physician. Even if you don't have benefits, there's opportunities there. Telehealth is a more affordable approach. So you could initiate a contact. You've got helplines, again, in both of our countries that are available that can provide a person a bridge to offering support. So in Canada, you've got Crisis Services Canada and the Crisis Text Line. In the US, we've got 988 and Crisis Text Line. I'll put a little list together, send it to you and Luke, so you're going to be able to share that with your readers. You also have nonprofit social service agencies, and you've got faith-based recovery resources. You've got groups like Alcoholics Anonymous, and you've got others for narcotics. The support groups are a great place. We're going to see a movement toward peer-to-peer support. It's gaining a lot of momentum. That's another thing that gives me hope. So we need to give people multiple options so they can find the right path toward recovery. We have to probably lose the assumption that there's only one way to recovery. And benefits are a great thing to utilize, but in many places there are more supports available than most people are aware of. It does take resourcefulness and a little bit of persistence and perseverance to find. But that's where friends and family, that's where loved ones can step